Hello. So I want to introduce you guys to someone who's going to be going over a few of these chapters with us for this section of the material. So we are currently on week 5 and 6. So this is Terry, and I'm going to let her tell you a little bit about herself, and then we'll get started on the lecture. So let me introduce to you a women's health nurse practitioner who's going to assist us with some lectures for DNP 520. Miss Terry.
So I'm Terry Herman. I have been a nurse for over 35 years and a nurse practitioner for about 25. I work at a local OBGYN office, and I've been there for 19 years and see a lot of interesting people on a daily basis.
All right. Let me make sure everything's working. Yep, we're good. So let's talk about gynecological infections. This is chapter 21. These are pretty short PowerPoint slides, and we're just going to kind of go through some stuff, and Terry's going to help us actually bring these things to life. So hopefully this may help you guys moving forward in practice in your clinical areas. Okay. So vaginal health, and you guys can read these. We're not going to read the slides to you, so you know how women need to learn how to maintain their vaginal health. So let's kind of flip through talking about the vaginal secretions. Terry, do you have anything to add about anything here as far as what's normal, what's abnormal with patients and their microbiomes?
So many women feel like any changes in their vaginal discharge, most of the time they're going to have discharge that can change throughout their menstrual cycle. Even women who are postmenopausal will have a normal vaginal discharge. Many times certain things can change the pH of the vaginal discharge, causing an infection, which we refer to as vaginitis. So the pH, we normally keep the pH at a normal level of 3.5 to 4.5. Whenever it creeps up to 5 to even 6 pH, you're going to end up with being at risk for developing vaginitis. Good and bad bacteria, and the bad bacteria takes over at that point. So they present with different concerns about their discharge, the consistency. It may have an odor. And of course, whenever vaginitis is involved, they're complaining of itching, burning, or itching, burning. So when in the office you're checking for vaginitis, they just need to be reassured that there are some normal vaginal discharges that are not infectious.
Okay, perfect. So let's look at life cycle changes. Of course, the talks about female newborns. So we all kind of know about that. You also should be kind of seeing some of this in peds, how following birth, a female infant will have some sort of discharge, and it can even have a bloody tinge to it. So in pregnancy, there's that increase in mucus production, of course, and before menarche and following menopause, when that estrogen level drops, then that vaginal secretion will start dropping too. Okay. So let's move forward. There's our vaginitis, which Terry has already talked to us about a little bit. And there's vaginosis. I know she's got some great stories behind vaginosis as well.
See, I see bacterial vaginosis daily in my office, and it's actually more common than the usual vaginal yeast infections. So I am checking for that probably 4 to 5 times a day in my clientele. We use a DNA type of test instead of the wet prep. I know if we get into that already, but the vaginosis is you don't see the increased number of white blood cells. So even though vaginosis is a type of vaginitis, you're not seeing the white blood cells like you would with chlamydia or an STD of chlamydia or gonorrhea.
Perfect. So we can move on. You guys can read that prevention measures. Of course, we all kind of know what that looks like. We kind of talk to your patients, even probably in clinical last semester, you talked to your patients about some of these issues. You've probably even seen this come into the family practice, not just women's health. We always have to talk about wiping from front to back, not using sprays, powders, douches, that kind of thing, perfume powders. I know Terry even talks about not using soap down there in that area as well. She tells her patients that on a regular basis, right?
Yes, ma'am, because we become sensitive in that area. And so experts say just using a clean water and washcloth to clean with, that is very adequate. And it keeps down your risk of becoming sensitive and irritated there.
Perfect. So here's what we know as BV, bacterial vaginosis, that fishy odor. Of course, I think the main thing that I remember Terry talking to me about with BV is the fact that the clientele that you get is just not just sexually active patients, which I found very interesting. So I'm going to let her kind of touch on that a minute.
So with BV, it can be a woman who has never been sexually active. Just her period can throw off that pH, putting her at risk for a bacterial vaginosis. But certainly once a woman becomes sexually active, she is at more risk of developing bacterial vaginosis just from having intercourse. Because of the changes in the pH. And certainly the menstrual bleeding, we encourage our patients not to douche because that changes the pH and puts them at risk for that. A new sexual partner, I know I'm reading this off, but that is the truth on that one. Some women, even though it's not a sexually transmitted, it's sexually associated. And with that new partner in their life, that can change the pH as well. Smoking, the lack of condom use, and we see that as well. Not considered race and ethnicity, but
yeah, I never thought about that particularly. Mm-hmm. Okay, so this kind of breaks it down on the assessment with the patient. Is there anything else that you would like to add in here as far as your assessment of a patient with BV? Is it very prevalent? Like, do you smell it and you're like, oh, no, it's definitely BV?
No, and some women may not have that fishy odor. And so their symptoms may not be classical. You may not do whenever you do a speculum exam, and you may not see that homogeneous white discharge that's telltale sign of BV. It may look like a clear, normal appearing vagina, normal appearing cervix, normal appearing clear discharge. But with their symptoms, you do want to check, and oftentimes you're diagnosing with the pH of the vagina as well as the DNA that's positive for BV. Wet preps can be done, but it really takes a trained eye to look under the microscope. And so our practice have started using the DNA to diagnose that, because things can be missed under the microscope.
Perfect. I have to say, I remember going into women's health clinical, and whenever my preceptor took the slide and she would sniff it, and she was even pregnant, and there were sometimes that she was like, ooh, she was could barely even hold in her nauseated feeling just from smelling. Yeah. So I never even realized that y'all actually go in and sniff these slides. So that was one big thing for me.
Under the microscope, I've been trained to do that, and I can do that if worst comes to worst. So when we're looking under the microscope, we do a swab from the pH, and then I will put some saline on a slide with the vaginal secretions, And then I put another sample and we use KOH preparation. That's what she's talking about with, and it's called positive amine. And it smells like you're walking through a fish cannery or something. So it is very strong.
Yep.
But for me, most times, and now certainly wearing the mask, for me, most times I can't really necessarily smell it on the average patient.
Good to know. See, this is why her experience is really prevalent for us to keep moving forward, because I love the fact that she's in it every single day. Okay, so there's management that says table 21.3. What would you say that you treat BV with, Terry?
So you can treat it with oral metronidazole. Most women want something oral rather than vaginal. Any of our treatments are equal in their effectiveness, but usually 500 milligrams of the metronidazole twice a day, usually 7 days. And I do encourage them to take it with food and avoid alcohol during this. Yeah.
No alcohol.
Yeah.
That's an absolute. It's the no alcohol,
no alcohol
for sure.
That will make them sick typically. And that usually takes care of the bacterial infections. If there's a reason why a patient doesn't want the oral or can't take the oral, we usually use the metronidazole vaginal gel. I believe that's 0.75%, and we use an applicator at night for 5 nights. We can also use clindamycin 2% vaginal cream. You can use that nightly for 5 to 7 nights as well. And any of those are equally effective for bacterial vaginosis.
Perfect. Perfect. Do you see one versus the other being more effective? Have you ever had anybody come back and have to have anything different?
Absolutely. There is many women who may have built up a resistance. So if I have treated her time and time again with oral or even the Metrogel, I'll change to the clindamycin vaginal cream.
Perfect.
Yeah.
I was just curious because I've seen that as well. So I was just
if
kind of
you have, so our most popular times for coming in with a vaginal infection is right before a holiday or right before vacation.
Of course it is.
Yeah. And so they're saying, I've got something big this weekend. I'm going to be drinking alcohol this weekend with a party or whatever. You can use the metronidazole vaginal gel. It won't cause them to be sick. And they may have that preference of the vaginal cream or gel over the oral in that instance. So that's possible as well. Perfect. There's also tinidazole that you can use, which is related to the metronidazole, and that's a quicker treatment.
Okay.
And oftentimes that works, but sometimes the insurances, and that's of course important when you get out in clinical practice, the insurance paying for their medication. So if you can get that covered, that's certainly an option to use.
I remember having on my tabs on my computer the $4 Walmart prescriptions, because you always want to keep those on check for patients who come in who may need to have a $4 prescription. So that's always a good hint for you guys that are in clinical too. Okay. So now we're talking about candidiasis. I can't ever say it. So yeast infections, right? Mm-hmm. Okay. So let's talk about this one. Anything that kind of stands out to you? There's risk factors there. Of course, you guys kind of know what that looks like with yeast infections, people in swimsuits, that kind of thing. Let's see. There's your symptoms: the thick, white, lumpy discharge, cottage cheese kind of things, looking at the speculum exam. But I know you have said yourself it may not be totally textbook. Once again, we love these textbook scenes, but not everything is textbook. That's why we have differential diagnoses. So take it away, Terry.
So we get excited when we see the cottage cheese. Oh, you got yeast. You could see it first off as soon as you put that speculum in the vagina. But many times you're not going to see that curdy white discharge or curdy yellowish green discharge. That's pretty typical as well. It doesn't say that, but that's what I see. With the differences between vaginosis and yeast infections, you're going to have more erythema in the vagina with yeast infections. You may even see a swollen labia or a red labia. So that can be a sign that that's what you're going to end up treating. Now, certainly you can't take that as your total diagnosis without doing the complete pelvic exam and swab. But many times, I don't know, a patient has symptoms of a yeast. She may not be itching. I'm doing a pap smear on her, and her pap smear will come back with evidence of candida on her pap. So,
and you said that to me.
Yeah.
We actually had a conversation about what this looked like, and she said that she didn't feel like it could have been that, but when she swabbed up inside, you couldn't tell on the outside, but when she swabbed, she found it. So, that's what a good nurse practitioner does, right? So she's looking at everything, rolling out everything.
Exactly.
So that's good.
So, and then certainly are we to treatment?
Yeah, let's keep going. Sorry.
Any of the azole medications, first line truly is over-the-counter monostat. That takes care of more vaginal yeast infections than the fluconazole.
Wow.
Yeah, but everybody wants the pill. So they don't want to deal with the creams or the over the counter. And it's not real fun whenever you're woke up in the middle of the night on call and they want diflucan to be called into their pharmacy.
Unbelievable.
But yeah, it happens. But yes, they can self-treat at home by using the miconazole 3-day. I warn them personally about the 1-day treatments.
I was going to ask you that. So
many times it's such a strong dose at one time, can take care of it, but then they're in your office again because they're allergic to that 1 day.
Wow.
No, they're not. They think they are.
Yeah.
But it's because it's so strong and it's burning and there's nothing that they can do about it except wait it out.
Yeah.
But so I usually, if they're going to do a 3-day or something at home, they can use the 3-day miconazole or even the 7-day if they want to use that. It's even weaker, but it does work. Clotrimazole, they can use that. That's over the counter as well. Diflucan or the fluconazole, the 150. Let me just give you some pearls. The 1 tablet does not work. If she is symptomatic, it will not work in most cases. So I usually treat at least with 2 tablets or even 3 if they are very prone to yeast. You don't want to use it day after day. I've seen that by some primary cares. You want to usually repeat after 3 days whenever you're writing for the fluconazole. Yeah.
Good job. I love it. Perfect. So let's talk about atrophic vaginitis and genitourinary syndrome of menopause. Anything you can touch base with this?
Yes, I see a lot of this. This is a very common change that we see that's normal after menopause. Most women in their lifetime, if they live long enough, will experience this. It's more of a problem for women who continue to be sexually active after menopause. So someone who is older and her husband's already deceased, she may not complain that this is a real problem. However, I do see some women that have maybe been years in menopause and they're in my office and they're complaining of some itching or irritation. They're uncomfortable. They think they may have a vaginal infection. I check them for BV or yeast, which commonly see both in that woman. And even if she's not sexually active, and when I'm testing negative, it's usually the effects of atrophic vaginitis.
Oh, wow. Unbelievable.
So that can lead to, I wrote down here when I was looking over this, even in some women who have real severe atrophic vaginitis, they can start adhesing on the outside. Their labia can
Oh,
thin
wow.
out and even cause adhesions we call agglutination.
Agglutination.
Mhm.
Interesting. So do you agree with what our book says as far as like, you see a pH greater than 5, increase in white blood cells here as well, and do you manage the same way?
Very same way.
Cool.
Yeah, and women will ask you, sexual activity can help maintain their vaginal health. They've read in various places, either use it or lose it, and that's the truth of it.
That's funny. Well, there you go. So here's toxic shock syndrome. We all kind of have heard this, of course, throughout our lifespan, I'm sure. So is there anything you can add as far as toxic shock?
Read it just like you guys have, and I've never seen it in the entire time that I have been practicing, but it's certainly something that you need to be aware of. By now, most of our patients have, are aware of that possibility.
Right.
Whenever using tampons.
Perfect.
Mhm.
So I know that you have some interesting story about the Bartholin duct cyst and abscesses. So you want to hit that for a second?
So we all know what the Bartholin cyst is, or Bartholin glands. They provide the lubrication during intercourse and to the vaginal area. And women can at any time of their life form a little cyst of one of the Bartholin glands, and usually find that at 5 and 8 o'clock of the whenever you're examining, if you are looking there. And whenever a cyst is formed, a lot of women are asymptomatic. They may feel it on the outside, but it's not bothersome for them. And at this point, we don't do anything about that. It can abscess, and it can happen overnight. And they're in your office saying, I can't walk, I can't sit. I've got this bulge. And some cases it looks like a chicken egg.
Wow.
That has formed of the vulva. So and the way that whenever you are assessing them, I use my finger in the vagina, and you can actually press the cyst or the abscess between your fingers on the vaginal wall.
Yeah, I can see how you can do that for sure.
So and by the time that they develop an abscess, they can hardly stand that.
Wow.
It
And I
hurts
know
so
you
much.
told me that you've actually been referred, a patient got referred to you who had what the provider, the primary care provider, sent over a patient and said that the patient they thought had a Bartholin duct cyst. However,
it was a good old fashioned carbuncle boil.
That was it.
So to be diagnostic, it does invade the vagina or the vaginal wall. So you can actually feel on the inside of the vagina, you can feel that cyst or abscess.
So it's very important to kind of make sure you know exactly what you're talking about when you're examining a patient, okay? Because that's kind of one of those situations where it wasn't what the primary care provider, thought it was. So that's kind of unique as well. Genital piercing, I mean, it is what it is. Anything? Not really.
I see it all the time. And, certainly they're more prone for infection and keloid formation. That is a possibility, but I see it a lot in the younger women, not too much in the older women, but it has become more common.
All right, perfect. So we're going to go on and jump into sexually transmitted infections. So, of course, you guys can read all of this. We're not going to go through some of these things. We're just going to kind of talk to Terry about what she thinks or what she sees more commonly in her office. So y'all can read all of this stuff, which is kind of what's some epidemiology going through So we'll start here with chlamydia and gonorrhea. What do you think that you see most often in your practice?
Definitely chlamydia.
Okay.
Years ago, used to see gonorrhea every once in a while, but
I think I skipped everything else, didn't I? Hang
yeah.
on. I skipped
We're gonna
everything
back
else.
up.
We're going to back up. We're going
Okay.
to back up a minute because I'm just like skipping through everything. Special considerations. Now, HPV. Let's start here.
Yeah.
How about that? Back up. All right. Here we go. HPV genital
Okay.
warts.
Is the most common viral STD there is. It's prevalent. I think this generation worldwide, it's estimated that 80% of the population will be affected by HPV. So that is true information that you're getting. I see it every day, so in some sort of instance, whether it's an abnormal pap smear or genital warts. It's out there, folks, and it is. I spend more time when they've been diagnosed with an abnormal pap because of HPV. They're in there crying because they feel like they've been diagnosed with cancer.
Right.
So
yeah.
it's very disheartening when, even though it's very, very common, it's when you're that person that's been affected, it's very disheartening. So we do talk about the vaccine. I do encourage women to be vaccinated, to vaccinate their children, boys and girls. It's a good time, even though you're seeing the adults, to talk about protecting their children as well. The vaccines can now be given up to age 46. We still have a problem with insurances covering the women over 26 to that age 46, but more and more insurances are beginning to pay for that. One of the things that they're concerned about was, okay, they've already been diagnosed with a strain of HPV. Should they get the vaccine? Well, the vaccine will not take care of the specific strain that they have been affected by because they've already been exposed to it. However, it will protect them against the other strains that they may not have been exposed to. So,
and that's great information. I think somebody in this cohort is actually doing their project on Gardasil. So I'm pretty interested in that because I'm a very big advocate as well of this vaccination. All right. So genital herpes.
Herpes I see pretty commonly. I don't have statistics on that, but I typically talk about it once a week at least, on a regular basis. When if you've got somebody who comes in and they're complaining of pain, they've got a bump they want you to look at, the bump was itchy, but now it's just painful. You need to consider that herpes is a possibility. We see both HSV2 of the genitalia as well as 1. We see that probably as much as we see the HSV2.
Now, do you think that, and I don't mean to interrupt, but do you think that some people just don't understand, like the public doesn't understand that if you have a breakout of HSV1 and you are doing oral sex on your partner, that they can get HSV1 down there? Do you think maybe that's just kind of a lack of education?
They don't know that. Okay. They don't know. They never thought. Yesterday I had a lady that we were suspecting before I ever examined her. That's what was going on. And she said, yes, my husband has fever blisters. And he very much enjoys oral sex. So I said, well, that's certainly something that we need to look for whenever I was going to examine her. So yes, probably as much as I see the HSV2, that's a real possibility. And certainly I'll do a piece, I think it's PCR or a DNA on them. And It will test for not only the herpes virus, but it will break it down to HSV1 and HSV2.
That's cool.
Somehow or another, a married woman who's been diagnosed with herpes is more comforted to the fact that it's HSV1 and she got it from her husband.
Yeah, of
through
course.
oral
I
sex.
can imagine that for sure. I
Absolutely.
could understand that. As far as treatment with this, I know there's a lot of different things like acyclovir and Valtrex.
Mhm.
What is your go-to?
Usually the valsaclavir, because it gets to the virus a little quicker than acyclovir. So I usually start with 500 milligrams twice a day. The earlier you can, I think it's before 72 hours that you can treat this, the better effective it's going to be as shortening that viral load
Right, of
to that
So it
treatment.
hasn't replicated as much. It hasn't had time to
Exactly.
do that. Yes.
And it's certainly with the first time they have an outbreak, this primary outbreak is going to be more than one place. Versus their usual outbreaks afterwards, they're going to have more lesions with the primary outbreak. So they're going to be more uncomfortable.
Wow.
I have seen it widespread on both sides of the labia. Oh, I've seen terrible, and they can hardly walk. But then other outbreaks is that I've seen, which was the primary, they may have 4 or 5 lesions that look like the vesicles. And so when you can identify that, more than likely that's your primary outbreak.
Wow. All right. Awesome. All right. Kinkroid.
Can I say something?
Yes.
Can we go back?
Yeah, we can go back. Of course. I'm sorry.
One bit of pearl there.
Yeah.
In the practice, even if you're in primary care, if you have, it's been proven that you have somebody who wants to go on suppressive therapy, if they don't want to spread this to somebody else. They've done studies on Valtrex or valsaclavir. If a person uses that as suppressive therapy, it reduces their risk by 70% to transmit it to someone else.
Really?
Yes.
No, I didn't even know that.
Yeah.
So I'm getting pearls of wisdom today myself.
So that's just, I want to pass that along
great.
because that can keep somebody from really not wanting to get into a
Yes.
relationship and still protect their partner.
So do you have a lot of patients on suppressive therapy?
Not a lot, but I do offer that to them,
Good for you.
particularly if they are not in a steady relationship. They could spread that to a lot of people.
Exactly.
But if they use that suppressively, now, number one, it keeps them from having outbreaks. But number two, it can cut that much from
70%.
Yes.
That's kind of a big statistic there. That's great. All right. Anything here? I know you said you barely see a lot of this.
the cancroid. I don't know that I've ever seen. And I worked in the health department sector for a long time, but that's something to consider when you have a lesion that's a single lesion. The pubic lice I used to see quite often in the teenage years. Yes. But trichomonas or trichomoniasis, that is on our the test we use for, we call it a BD affirm. That's I use commonly to test for a BV yeast, but it will also test for trick. If you don't have that in your office, you can do a vaginal swab and look under the microscope. You don't want to use KOH on that, but you want to look under the microscope with the saline, and you can actually see it swimming. So they do have the flagella. So it is fairly common, but I don't see it often.
Okay. So
when I do see it, I
do,
because maybe once every 6 weeks I might see that, and it's such a shock to the patient. But we do need to make sure that both partners are treated before they have sex with each other on that.
Yes. And sometimes that can be kind of difficult too, I've found.
Yes. Well, treating the partner.
Exactly. That's what I'm talking about.
Because with men and the urethral shaft is quite a bit longer, many times it's not caught. I'm not real certain how, since I don't see men, how that is diagnosed.
Right.
But certainly if you have a man that comes in your practice and his wife or female partner has been diagnosed with trich, you want to treat them with metronidazole. You treat them with a one-time dose of 2 grams.
So do you write prescriptions for the partner or do you make them go be seen? Good to
I
know.
do.
Good
The
for
reason
you.
for
Yes.
that is they may need to be tested for
Right.
other
Right.
STDs.
Exactly.
And I don't know legal terms of will I be
That's right.
covered to treat somebody I don't know.
Right.
There's some
Exactly.
doctors that will. I personally don't.
Good to know.
One other thing that if you're doing PAPs in your office, trich can be diagnosed on the PAP.
Oh, good. Wow.
And so what I've read when I was like, gosh, she's got trich. I didn't know it. I didn't see it in no symptoms, but I see it on a pap smear. That can be that has been found that it can be a diagnostic.
Wow.
Yeah.
On a PAP.
On a
Good
PAP.
to know.
Yeah.
Look at that. So there's some extra pearls for you guys for sure. So no chlamydia, gonorrhea. This is one of the big ones. I've written a lot of information because we kind of discussed a lot surrounding this one as well. So you see chlamydia the most.
Mhm.
Yeah.
I do. Barely. I can't tell you. And even in my 19 years of my private practice, I don't think I've seen gonorrhea maybe one time.
Wow.
But like I said, with it's certainly encouraged to screen women once they become sexually active up to age 25 annually. Insurances tend to see that you do that. But we do a DNA and we do ours in the office. So I'm usually get that back within 24 hours. And that's a high sensitivity on this particular thing. You can use a vaginal swab as well as urine to collect the DNA. So when we do see chlamydia, you want to get them treated as soon as possible because of the risk of the sequelae that causing PID, scarring, that can protect their fertility. So you want to get that person treated as quick as possible. So when I do see somebody with chlamydia, we treat them with 1 gram of Zithromax. It can be broken up into, for years I've used the little 1 gram packet that they take and drink, but you can use the 500 milligrams, take 2 of those at once.
Okay.
The partner again should be notified and treated. I usually say wait 1 week once both partners are treated before you're going to have intercourse. I usually recommend my patients come back for a test of cure within about 3 weeks. Not that the Zithromax does not work on that, but I want to make sure that she's effectively treated. So it's going to prevent sequelae on her.
Perfect.
One other, I couldn't find that this was covered, but something that's on the rise is urogenital mycoplasma or uroplasma. And we do have tests. I do have to send that out, but that is more and more when you cannot find a reason for her to have vaginal symptoms. This is something that we should be screening our men and women for, because this mycoplasma is on the rise.
Good to know.
Yeah, and it's sexually transmitted.
Wow.
For most cases.
Look at that. So there's something new there. So pelvic inflammatory disease, what can you tell us about this?
Well, this is a sick individual when they come in with PID, and most of the time they're going to the ER or to urgent care with PID, but I do see it in the office. It is where the infection starts vaginally and ascends up into the uterus and the fallopian tubes. And the telltale sign is the chandelier sign. That is a true sign whenever you touch the cervix and they're riding up the table when you're doing the pelvic exam. But usually they have the vaginal discharge that is very appears to be the purulent discharge. BV can commonly cause PID. In fact, I saw this yesterday.
Wow.
She thought that she had another kidney stone or a UTI. So she's a fellow employee, but as my patient, she come in my office, I tested her urine. It's like, you don't have a UTI. I could have swore I had a UTI. She's already been to the urologist. Then the next day she said, Terry, I'm bleeding. I'm bleeding through my urine. It's like, are you bleeding through your urine or are you having some vaginal bleeding? Well, I don't know where it's coming from. Like, okay, let me check you. So certainly she had vaginal bleeding. She's married. She's not sexually active at this point in her life. And I swapped her for with a BD Affirm to check just to make sure she had or did not have bacterial vaginosis, and bingo, that's what it was.
Oh, wow.
And she said, can this cause my pain and bleeding? And yes, ma'am, it sure can. So I'm treating her with oral metronidazole, and her symptoms should get better within a day or two.
Wow. That's very
But
interesting.
the pelvic inflammatory disease that we usually think is often caused by chlamydia, and they need to be treated. If you highly suspect this, I would go presumptively go ahead and treat them with Rocephin and doxycycline. It's really important that they be treated immediately with that.
Perfect.
Sometimes they have to be hospitalized, but
Oh, I can see that
Yeah.
for sure. So syphilis, complex infection for sure, right? Leads to serious systemic disease, even death if left untreated.
Yeah. And supposedly syphilis is on the rise in the United States. And when I have a patient that comes in and she's scared because she's found out her partner had other partners, she wants to be checked for everything. This is one of the things I do check for. Thank God I haven't had a positive.
Yeah, knock
So,
on wood.
But yeah, exactly. But you want to do an RPR on this person.
For sure. Pregnant women also.
Absolutely.
Yeah,
They're
always.
checked early in their pregnancy as well as late in the pregnancy before the delivery.
Yes. Yeah, didn't know that for sure. Hepatitis B. You see many cases of Hep B since the vaccination.
Not
honestly.
really.
Right.
No, but that's certainly when you're considering checking for STDs, when the woman wants to be checked for everything, I include hepatitis B and C
Oh, good.
in my hepatic panel. Yeah.
Good deal. All right. And there, of course, is Hep C. Now we've got some treatment for Hep C.
Yeah, thank goodness.
Yeah, so that's
We're
on the
seeing
rise.
more personally Hep C than we are Hep B since the
More
vaccine.
prevalent in baby boomers. You know, that
Mhm.
was kind of on the rise.
Absolutely. And so we do consider that, and doing Hep C panel for the baby boomers. That's one of the things I check for HCV. Mhm.
Yeah, I know there's a clinic in Hickory that actually that I did my clinical with that actually does the treatment for Hep C.
Mhm.
So that's like a big extensive process. They all
Absolutely.
get put in this group and they all get the treatment. So
Yeah.
it was pretty unique.
And they do use nurse practitioners and PA in that clientele to oftentimes when I get somebody referred to my office for treatment, not necessarily Hep C
Right,
treatment, but for other things with their PAPs, it's nurse practitioners that are treating these people.
That's awesome.
Yeah.
Look at that.
Yeah.
Love.
Yeah.
So HIV, what's your thoughts about this?
Well, it's there. I have several patients you would not think would be affected by HIV, but again, in this same clinic, I think you're referring to,
Mhm.
they do treat the HIV and they take great care. From my nursing career, when it barely had we knew what HIV was and AIDS, to now that they can treat so effectively, they can't even have traces of HIV in the bloodstream. That we've come great leaps and bounds.
It's so
for
cool that
treatment.
you've seen it from
I have.
inception all the way to
Yeah.
now we're able to treat
Yeah.
and take care of these patients more effectively.
So even my private sector, I have several women who live with HIV, but it's like not detected. Yeah. And their husbands or previous partners have spread that to them.
Wow.
Okay.
Unreal. So it's come a long way. So pregnancy, we kind of all know that it kind of can be there, believe it or not. And we're
Yeah.
checking these patients. We screen at least 2 times, at the beginning of pregnancy and then about 36 weeks. Anything you want to add to that?
No, this is off subject with pregnant women, but domestic violence is a higher rate during a pregnancy. But that same partner, they may have other partners during this time. We've even had cases where we've had 2 pregnant women and the same baby daddy for both.
Really?
Uncomfortable situation. But
Well, I was a labor and delivery nurse first, and I can tell you that I've had women who were negative at first and they test positive later on in the pregnancy. And, that's their first assumption as nurses is, well, your partner probably cheated on you, because you're pregnant. So, which is a terrible assumption. But however, that always kind of clued us in.
You need to think about that patient herself can be the
Exactly. So this concludes what we're going to do. We're going to touch base and get together and do urinary tract infections next, but we're going to take a break here and let you guys absorb what you've learned so far. So thanks so much for listening.